Now we will move on to presbyopia correction during cataract surgery. I would like to invite Dr. Ashraful Huq to share his screen and give his presentation on incorporating presbyopia correction during cataract surgery.
Thank you, Dr. Maziba. Is my screen visible and I am audible?
Yes.
Assalamu alaikum. It's an honor and have a great opportunity to present in front of my mentors, and I would like to congratulate and show my gratitude to BSCRS for involving me. So incorporating presbyopia correction during cataract surgery and how I started. It's a story rather than surgical tips. So nowadays, the cataract surgery is not only the cataract surgery, it's become a refractive surgery. And when after the cataract surgery, we can manage the patient without glass, good vision, the patients become happy. And the happy patient always makes the surgeon happy. So, but starting for the premium IOL like multifocal IOL and the presbyopia correction. So was the barrier for me when I thought that I will start the presbyopia correction? The most fear was the outcome. Will my patient be happy? Will my patient become the 6/6 or N6 vision near after the surgery? And what should be the biometry? What will be the power I calculate? And definitely the most mental barrier was the cost of the package. I am offering the patient a higher package surgery. Will the patient happy after the end of surgery? These are the barrier for starting the multifocal IOL practice. But the urge of becoming a refractive surgeon in a surgeon is the most important thing. And when we check the K1 and K2 in our biometry in every monofocal lenses and check the target refraction of the monofocal IOL implantation and monitoring the postoperative refraction of my routine cataract patients, it gives me confidence that yes, my routine cataract patient, they can see 6/6 after the surgery and they're seeing good, but they are not happy. Some patients are not happy that they need reading glass after the surgery, though they can see clearly distant without any glasses. So that's make me determine that yes, I need to offer multifocal IOL to the patient. And when we are offering the multifocal IOL to the patient, that is the initial choose phase, and choosing the ideal patient is very important. The patient who are desperate that yes, I don't want any glasses after surgery, either it is near, either it is distant. These are the very good candidate for the multifocal IOL implantation, and the less demanding patient. The patient, when we do the counseling, the patient who have confusion in every questions and every answers, initially for starting the practice, they are not the good candidate for multifocal IOL implantation. And obviously, no other ocular pathology and any ocular pathology should be ruled out for a suitable candidate of the multifocal IOL. And when we start the multifocal IOL, though we are doing lots of monofocal IOL implantation, the surgical steps are pretty same like monofocal IOL. But what should we consider of implanting the multifocal IOL? Number one is biometry. We have to check the biometry. Number two, surgical steps are same, but in every step, we should be and we need to be careful. And we have to keep in mind in perioperative time, we should avoid any kinds of complication. So here I'm showing the biometry. We are seeing and checking the biometry before the cataract surgery. But one thing for the multifocal IOL choosing patient is very important. That is my K1 and K2 value. My K1 and K2 value, a difference should be less than 1 diopter. If the patient has the more than 1 diopter of astigmatism, the patient will never be happy in only multifocal IOL implantation. The patient need for multifocal toric IOL, that will be the separate chapter. But for only multifocal IOL and only presbyopic correction, we need to have thing that the patient has the less than 1 diopter of the astigmatism. And other procedure of the biometry are the pretty same. We can go for toric, we can go for SRK. And here I am showing the IOL master, but in ultrasound biometry, immersion biometry, that also gives us a very good IOL power for choosing the multifocal IOL. But one thing is very important, keep in mind when we do the biometry, the A constant of the multifocal IOL is very important, and we need to put the A constant, that a constant of the multifocal IOL in the biometry. This is basically the first case of my multifocal IOL. She is a 65 years old female, and in the multifocal IOL surgery steps is pretty same, but the rhexis is the most important part. I need to have a good rhexis because I want to capture all my IOL in the rhexis, and the surgical step is very pretty same, but need to be careful. And also in when we go for the cortical removal, we need to have proper and full cortical cleaning. We don't want any post-operative capsular, posterior capsular opacity. That is very important. And we need to have the meticulous polishing, because when the fiber are attaching in the posterior capsule, with polish we can have the remove this. And inserting the multifocal IOL, this is pretty same as monofocal IOL. Here I was using Restore. And after inserting the multifocal IOL, the most important part is that we need to remove all the visco from the eye. And also we can see the two Purkinje image. One image is in the cornea and one is IOL. We need to match it before we closing the surgery. And that patient, what I did in 2018, the first POD vision was unaided, distant vision was 6.6 and near vision was N6. And this is the actual post-operative first POD picture of that eye. And when we get the result of these kinds of surgery, this gives us the high confidence that yes, we can correct presbyopic in our cataract surgery, and we can offer patient further for the multifocal IOL implantation. So my take-home message for the presbyopia correction is that though we are doing the monofocal IOL in our routine practice, the mind setup that we will keep our mind open, that we can offer the patient that yes, you can go for presbyopic correction, that you will not need any glasses after the cataract surgery, that is distant or near. And obviously the proper preoperative evaluation is very important. And with this, if we are aware of this and you can keep in mind, and we are determined that yes, we can go for not only cataract surgery, we can go for cataract and refractive surgery, that will give us the confidence and we can go for cataract refractive surgery. Thank you very much.
Thank you, Dr. Ashraf. I know that your presentation will give many a surgeon confidence to start their presbyopia correction during cataract surgery. And now we will hear from the expert. I would like to invite Dr. Mahbub Rahman Chaudhry to give his presentation on presbyopia. Sir, will you please share your screen?
Is my screen visible?
Yes, please go to presenter's view.
Is that fine?
Yes, please. Thank you.
Thank you, Dr. Ashraf, so for a wonderful presentation. And I will just give some overview of the presbyopia correction during cataract surgery. And I thank Marziba for giving me the opportunity, and also I thank the President, Secretary, and the whole Executive Committee for organizing this webinar. And as Dr. Ashraf said, cataract surgery was vision restoring surgery, but nowadays it is a refractive surgery. So we should look into that this status that it is actually a refractive surgery now. So that's what we are aiming at. So what is the aim? As Dr. Ashraf said, quality vision for distance, for near, for intermediate region. So we want to have vision for all range. That is the aim. And if here, two things is important: selection of patient and counseling of the patient. And this is more of an art than science. So we have to take some time here, and we have more time here. The chair time is very important, explaining to them, converting normal cataract surgery into the refractive surgery. So the chair time is very important. And this is an art that we have to master if we want to be a refractive cataract surgeon. And as Dr. Ashraf said rightly, who are the patient? So initially we should see that we have to make a judgment so that this patient become happy and this patient doesn't become chronically a problem for a surgeon. So we want to select the right person, and the ideal persons are those who want to reduce their dependency on glasses, those who are motivated, those who have a fashionable and cosmetic lifestyle, and those who are ready to go for bilateral implantation in short period of time. And as Dr. Ashraf said, it should be the astigmatism part. We must look into this, that it should not be more than one diopter. And some patient, as we know, that they are complaining sort, patient with unrealistic expectation, complaining patient about glasses or contact lens, and those are night drivers and with ocular pathology. So these are the people we want to avoid so that they don't they don't blame the multifocal lens or the trifocal lens or the EDOF lens. It is the counseling part and is the selection part which gives the most important in this effort and in this criteria. So when we are counseling, we have to explain to the patient this: the cataract surgery is now, this is an opportunity to have the best of the vision, which you never had. So we can explain that. So you take the best. You should take the best because this is an opportunity and you must avail it. So if we can explain it to them, and we'll say this, the quality of life will be much better. We'll be able to see most of the things without glasses. And the cost part, we'd say, if you buy 5 pair of frames and lenses, this will bear the cost of the surgery, which is of premium quality. So, and we have to insist that to get the best result is the bilateral surgery is the most important, and there is neuroadaptation and other things are related. So we will say that we will get the best result when the surgeries on both eyes are done. So we take a lot of time for selecting the patient and counseling the patient. These are two important aspects I will emphasize time and again before we go for this. And at the same times, we have to point out some of the limitations that with the patient will see halos, will see glare, and will take some time for neuroadaptation. So if we explain this thing to them beforehand, they will be not disappointed, and at the same time will not emphasize this limitation so much so that they will become scared to use the multifocal lens. So there has to be a balance between how much information we want to give, and at the same time how much information we need to preserve. So pre-operative evaluation is very important, as Dr. Ashraf was saying, that am I going to get a good result? And this is one of the barriers that we have in our young ophthalmologists who are about to start this presbyopic correction or toric correction. So this barrier has to overcome, and this accurate biometry is one of the most important factor, and this is the most important confident. It will give the most confidence if we have proper biometry done, and if we get the target refraction for, let's say, if we select 30 or 50 patients that I'm doing monofocal, am I achieving that? Am I achieving that? If I achieve my target refraction, I know that I'll be able to do a good presbyopia correction as well. So as Dr. Ashraf was saying, we should look into the biometry very, very meticulously, especially if there is there any cylindrical power here? It is more than, is K1, K2 is more than 1, then we should avoid it. So we should ask the patient to go for toric lens rather than the presbyopic correction. And if they insist, we can prescribe what we call the toric multifocal lens. So biometry, we have to consistently achieve, and at the same time look for astigmatism and the new generation formula. So Barrett toric calculator is the most important formula that we use now, and this is so helpful, and this is so easily available in the website of APA-CLS. And we have to, since this is a presbyopic correction, we have to see the retina, cornea, glaucoma, amblyopia, dry eyes, because if these pathologies are there, the patient will tend to blame the presbyopia correction lens for their dissatisfaction. So we have to look into this before we go for cataract surgery. Surgery, as Dr. Ashraf is saying, is same, but for myself, I take 1 or 2 minutes extra because I have promised the patient a premium lens. So I want to see that the REX is properly done. I want to see that all the steps are done, and I want to prevent complications. So I take few minutes extra while doing the surgery so that I can implant the lens that I promised the patient. So there's the same surgery, but what I want to emphasize is that we have to take extra few minutes so that our surgery can be done smoothly and also without complication. So this I won't. I will go to the next view. So, this is one lens that we have used, and I will go for this. The time is short. This is the Adolph lens. The other one was the panoptics. So this is what we want to show. And as Dr. Ashraf said, the two Purkinje images should match. So that is we know that the centration is right. The patient satisfaction will be also very. And how to start? As Dr. Ashraf said these are the mental barrier. And we have to be a good phaco surgeon. And we have to achieve consistent target emmetropia for biometry. And we have to record this. And we have to take this mental barrier that I am a good surgeon. I will be able to give the patient the best result. And the best confidence is performing one surgery, as Dr. Ashraf and Dr. Zakia Wadud has said. And we have to first patient should be selected very meticulously. They should be motivated, and the patient who is not fussy, and maybe a housewife, it would be an ideal patient to start with. So with this, I thank all the organizer for giving me this opportunity, and thanks for everybody for giving me the patient hearing. Thank you.
Thank you, sir. That was an excellent presentation, and you seem to make all the surgeries so easy.